Maximizing Clinical Nurse Specialist Values is our episode topic. My guest is Dr. Mitzi Saunders, an advanced practice registered nurse, clinical nurse specialist, and president of the National Association of Clinical Nurse Specialists. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Misty, thank you so much for joining me today.
You're welcome, Nick. Glad to be here.
So let's talk about the roles of CNS a little bit. What exactly is a clinical nurse specialist?
A clinical nurse specialist is an advanced practice registered nurse. So that means we're one of the four categories. There's nurse anesthesiologist, there's nurse midwife, there's nurse practitioner, and then there's clinical nurse specialist. So we share the same type of courses as you would get. They're called APRN core courses that all of those APRN groups take. So those are your advanced pathophysiology, advanced pharmacology, advanced physical assessment. We are all APRNs, but it's how we use that skill set. So for the clinical nurse specialists, our patient population are complex care patients. So you're not going to see a CNS working in urgent care, diagnosing and treating patients with, say, sore throat or urinary tract infection or ankle sprain. CNSs are concentrated where patients are most complex. So that is primarily the hospital setting. So 90% of clinical nurse specialists are in acute or critical care environments, seeing complex care patients. Now, the other population that we care for are the nurses. So we tend to also see the nurses who need more support, the nurses who need a little more coaching. They need role modeling of care at the bedside. So they're also our population of patients, if you will. And then the third part of the CNS role is fixing all the system issues. Everything that's going wrong in healthcare today can rest with the clinical nurse specialist as well. So we function in three spheres: patient, complex care, patients with acute decompensated heart failure or diabetic ketoacidosis, very sick patients, lots of comorbidities, the ones that we believe will have poor outcomes if they don't get more support. So the CNS role is less known to the public because unless you're really sick or you have a family member, say, who's on a ventilator, fighting for their life, people that are really sick, you don't necessarily have contact with clinical nurse specialists because that's where we reside. Now, more CNSs are transitioning into non-acute care, right? We know the medical home is becoming more and more acute. There's the transitional care role that we're seeing more and more CNSs moving into. So those are about 10% of CNSs who are also following patients with really complex needs out into the community. But primarily, Nick, it is the role of supporting the nurse. It's that frontline care worker that really draws most nurses to the CNS role.
So how does the CNS differ from other advanced practice registered nurses?
So the similarities are the core courses in the education. So those are those three Ps, right? The patho, the pharm, the physical assessment. And all of those roles go on to demonstrate and supervised, mentored clinical hours lots of HMPs, lots of progress notes, meaning lots of diagnosing and prescribing. Because when you think about it, what differentiates the RN from the APRN? It's the ability to diagnose and prescribe. So when you get out into practice, we all use that in different ways. The nurse midwife, mom, baby, the nurse anesthesiologist with anesthesia, the nurse practitioner, primarily in more non-acute care, primary care roles. The CNS is not trained to be a primary care provider. The CNS is trained to be in real time, complex care and situations so that the nurse does not have to chase down physicians and other advanced practice providers when they need an order. Now, you think about a nurse practitioner typically sees 3 patients an hour. That's not the clinical nurse specialist, because when we see a patient, and I'll use the acute decompensated heart failure, you may be with that patient for a full hour, right? Just going through everything they need, all the coordination of care, pulling all the services together. And then when the doctors and everyone goes away, the CNS is still there working with the nurse to make sure the plan of care is being rolled out appropriately and making sure they have all the resources, all the evidence-based practice resources that the nurse needs to really facilitate that patient's plan of care.
So, what are some of the unique qualities about being a CNS? What type of nurse would want to become a CNS?
I'm a longtime professor. I worked as a CNS, then I became a professor and have run a CNS program since 2007. So I can tell you from that experience why nurses choose the CNS role. And most of them do not like the status quo. They do not like what they are seeing out there in healthcare. They are people who want to see change. They are ones who run to complexity instead of going the other direction. So they want to change the system. They want to lead. They want to govern. Many of these nurses have already had some leadership in some governance type work that they're already doing in their facility. And oftentimes they say, I don't want to go from patient to patient, which is really the other APRN roles. They want to do more. They want to see patients, but they also want to improve care, frontline care at the bedside. So when you think about the CNS rule and a CNS education, we have this area of direct care competencies. Yes, HMPs, progress notes, diagnose, prescribing, again, complex patients. But we have this whole set of competencies for nurses that we learn about principles of adult education, how to change people, a lot of change theory, a lot of change projects are in a CNS education because we know we have to change the behavior of physicians, of nurses, of other people providing care in order to get the best patient outcomes. And we're really there to support the nurse. So when you think of why the CNS role was created and why it was for those complex care situations. It was for nurse retention, and we know we could use that right now, as well as really developing the professional skills of the nurse. All right. So many who go into becoming a clinical nurse specialist, they love nursing. They see nursing at a much higher level than what it's being practiced today, and they want to see it get to that level. Now, the other piece too is there's already leaders and they want to lead at a higher level. So also part of a CNS curriculum, Nick, is project management. So you also develop skills at being a leader and running change projects. And they do multiple change projects in a CNS program.
You were talking earlier about the 3 spheres of the CNS, the
Mhm.
patient, the nurse, and the processes or the outcomes and working on project management. I want to focus in for a moment on the second sphere when you're talking about the nurse. What is the difference then between a CNS that is working with nurses as opposed to, say, a clinical educator on a unit? Where does that distinction lie between those 2 roles?
Yeah, that is the clinical expertise. It's solely the clinical expertise. Say I develop a CNS who comes to me with experience in orthopedics. She already pretty seasoned nurse in orthopedics. So she wants to develop that, or he, to this higher level. So they do at least 500 minimum clinical hours, really developing that expertise in that particular area. Now, if you are, say, a master's in nursing education, which would be the education for a nurse educator, you are solely focused not on developing clinical expertise. You're focused on principles of adult education, right? How do I get this person to learn better? But we know that in real time, you can have people in a classroom learning how to do something, or you can be in real time as an elbow consultant with a nurse doing the cares together, showing them, come in with me while I have this very crucial conversation with the patient and family who need to go into hospice care. Come and watch me do this so you can learn the skills of doing this. So that's the difference, Nick. It's having that clinical expertise in real time with the nurse in patient care, showing them this is the best way to do things. And that's what we see from our chief nurse officers who use clinical nurse specialists. They talk about their ability to change nurse behavior in real time because of that clinical expertise. It's that role modeling that I think is so important. The CNS is often going to various meetings because they're representing nursing at different meetings. And what I hear from CNSs is this would be another distinction because you wouldn't necessarily have a nurse educator going to the meetings with the C-suite because the CNS has the opportunity to change care at the front lines. So when you're in these meetings and you hear some initiative coming up that could really alter nursing care, nursing practice for the worse, it's the CNS who's going to speak on behalf of the nurses because we are intimately familiar as clinical experts with what is going on. So that's a primary distinction. And there's a lot of roles out there that are missing that clinical expertise to really make the difference.
Aside
Yeah.
from presence in those meetings, what are some of the attributes of an effective CNS program? Or perhaps maybe a better way of asking the question is, if I'm a nurse executive right now in a healthcare organization, how do I know if I am maximizing the skill set and contributions of my CNSs?
Yeah. So I love that question. The first thing you want to make sure is that they're functioning at the APRN level. And what that means is when they came in, or if you have them right now, they should be credentialed and privileged. And that means that they can see patients, they can write orders, they can write for medications so that when nurses need something, they can come to the clinical nurse specialist to go in and assess the patient and write the order so it doesn't slow down care. So you're maximizing your CNS if you have them at the APRN level, and that means credentialed and privileged. So that would be the first one. The second piece would be, are they producing outcomes in patients with complex care needs and in nursing? Because, Nick, they learn in their CNS education how important it is to articulate your outcomes. They learn how to create dashboards. They learn about the importance of quarterly reports. So they should be reporting on lengths of stay in populations of patients who tend to have poor outcomes. Maybe like your heart failure population. Are we decreasing the length of stay by 1 day safely? Are we doing that? Nurse sensitive indicators are also very important to the CNS. So infection rates, fall rates, nurse satisfaction, nurse retention, readmission rates, costs of care, documentation, all those things are within a CNS curriculum. They are the things that CNSs learn about. So they should be producing those outcomes and showing them to the C-suite on a routine basis. So that's the second thing. And then the third thing is, are they leading at least one major project and initiative that is flowing across the system? Because they are system level leaders. That's what they should be doing. They do multiple projects and one big change project in CNS curriculum. So they need to be leading at least one major project, and they're your sustainability factor. They're not just coming in, doing a project like a DNP project or something, and then leaving. They're your sustainability factor. So they're initiating the project, leading the project, and following the project over time, which is so important because we see so many projects get initiated, We don't necessarily have someone there to sustain them. And I've heard different people saying with the DNP projects, we got this going, but now I'm done. Who's going to carry this forward? And I usually raise my hand when I'm at those meetings. That would be the CNS. That's the CNS. That's your sustainability. And then I think, Nick, the fourth part is it's just where are you using them? Because they need to be with populations that have the most complex needs. That's what nurses come to the CNS program looking for. It's that level of complexity. So you're not going to find, like I said earlier, you're not going to find a CNS at a minute clinic or not diagnosing sore throats or anything like that. It's the heavy duty stuff. It's maybe elderly population at risk for hospital-induced delirium. Maybe they fell last night on top of everything else they've got going on. So those are patients for the CNS to go in and work with, the ones that really need more support.
And so they're almost, just for my own clarification, they're almost always employed by the healthcare system, not necessarily by a physician practice group. Is that correct?
That's correct. But I just want to add this. I had a conversation recently with an orthopedic surgeon, and he was interested in what I was doing. And when I said, who I was and the clinical nurse specialist and all, he said, what exactly is a clinical nurse specialist? Is that like a nurse practitioner? And I said to him, in some ways we are, but we focus on patients who are most complex. And knowing his practice, I said to him, this is what a CNS would do for you. When you're in surgery, you could have the CNS rounding on some of your difficult cases, ones that you've already operated on. Or they could be in the clinic seeing your most complex and difficult patients. However, they also do indirect care, meaning they need to look at your practice, see where your inefficiencies are, and spend maybe half a day a week looking at data, analyzing data, and coming up with some solutions on how you can better deliver care in your practice. And his comment was, where can I get one? I need one on Monday. If you explain that way, people can understand it better and they can see a need for a clinical nurse specialist in most medical practices, I would say. And my students, I graduate, Nick, anywhere from 12 to 20 every December. My students graduate. I have probably 3 or 4 that go into practices like that.
Interesting.
So,
Not with the hospital, with a
yeah,
practice.
that's right. Yes. So those options are out there. And the other thing, Nick, we see more barriers in larger healthcare systems for CNSs to get credentialed and privileged than we do in small practices. So sometimes CNS students, my graduates, they choose to go into those practices because they know they're going to be able to practice at full scope and not face the barriers that they run into in larger healthcare systems.
You've used the words patient population a couple of times, and so I'm thinking if I'm a leader of a hospital and I'm looking at either putting in place a new CNS program, or trying to evaluate its effectiveness, does it make more sense to group them around disease populations or units and understand relationships on that? Like, where do I go with that patient population versus a unit-based CNS, if that makes sense?
No, it makes total sense. So I can speak to myself as a med-surg CNS. I worked with 6 physicians. I had a collaborative practice model, and my patients were scattered across 4 different units because I concentrated on heart failure, COPD patients, pyelonephritis patients, osteomyelitis patients. It was a certain grouping of medical patients that I followed over those different units. But you could have a unit that is pretty well concentrated, like orthopedics. If you had a very concentrated unit like that, you would probably want a CNS just over that unit because we are population based. And that last word in our title, specialist, means something. It means that you're specializing not generically over 4 or 5 units, but you're really specialized within a setting, like the emergency room setting or a population. Another setting would be the peri-op. We have a lot of CNSs that go into that peri-op setting as well.
What do they do?
They're really looking at inefficiencies in the system, and they're
Okay.
making sure
So
it's
that third sphere that you were talking about
it,
before.
it would be more the third sphere and the nursing workforce, making sure that they have all of the tools and resources necessary to practice at their highest level. They can see patients if there's more complex patients in that area. They could do H&Ps. They could do a lot of things, fill in different ways. And I will say, not necessarily in that setting, but even procedures. I know the physicians would give me more and teach me more and more. Every time a patient pulled a Dobhoff feeding tube out, they taught me how to put one back in, order the study and go down to the radiology department, make sure everything's in place and get the patient back on tubes. And I would bill for those services, which is so important, the billing aspect for CNSs to capture all those costs, all those things that they're doing. But you find in every setting, whatever physicians are doing could be transferred over to the clinical nurse specialist. Now, I'll make the point really clear. We are not primary care providers. We're not here to replace physicians. We are here to complement the work of physicians and other advanced practice providers. Because I don't prepare students for primary care. That's not the CNS role. It's really in real time, complex care, patients who need more support. And we know we're not suffering for patients that need more support. We know the complexity in the hospital system. So there's plenty of patients for the clinical nurse specialist to see, to work with the nurse and the staff on. And there was an interesting article that came out recently, and it was a report on an evaluation report of CNSs. And there was a comment made by a manager that the nurses breathe a sigh of relief when the clinical nurse specialist comes on the unit because they just know the support is going to be there and things are going to go more smoothly. So you'll hear sometimes people refer to the CNS as the glue that pulls it all together. And you don't have everybody working in silos, but there's that person that pulls it together. So over a unit or over a population, it's whatever your specialty is.
What does the future for CNSs look like?
I think it's very promising, and I'll tell you why. The fact that we have title protection now, which is huge, Nick, that not anyone out there can just use the title. We have title protection in 41 states. We have prescriptive authority or prescriptive privileges in 41 states. That's huge because that means that from that highest legal standpoint, CNSs can practice almost at full scope. Now, the barrier is still in the healthcare systems, but I will tell you that primarily our CNS students, the new grads, are much bolder in asking for credentialing and privileging when they get hired. So we're seeing that more and more. And I think that's so important to the CNS role that we deserve to be credentialed and privileged. We deserve to be the go-to person when orders are needed so we don't delay care by waiting for another provider to show up or someone when the CNS is there and can do the work. So we're seeing that more and more. That's very exciting. We have an NPI campaign, the National Provider Identifier campaign going on. And I know the American Nurse Association also has a campaign going on. And believe it or not, we're going to join forces. We're linking up with them because we're both doing the same campaign. And we're seeing a lot of CNSs getting their NPIs, which is important for billing services. We're also we would love to get a bill going for 100% reimbursement for CNS services because, again, when the CNS fills in and does something within their specialty, it's because we're complementing the care of these other providers, like the physicians. We're not taking anyone's place, but the CNS should be reimbursed for those services that they are specialized in doing. So for those reasons, I would also say that the National Association of Clinical Nurse Specialists is getting stronger and stronger, where our membership numbers are really growing, which is a positive thing. We attended Hill Day in Washington, D.C. in June, which is an opportunity for us to be face-to-face with representatives in Washington and really talk about healthcare issues and access to care issues. And we did that. We had a group that went to Washington. And we're even looking into having our own mini Hill Day. So where CNSs would go to Washington on our own and advocate more on our behalf. What we really need, though, Nick, is the demand. I still feel the role is very underutilized, undervalued, and it's an important priority coming from the National Association of Clinical Nurse Specialists that we make the public more aware of the role. And that is one of our strategic priorities, is to get out there more and talk about what the CNS can do.
Great. Any closing thoughts as we wrap up this episode?
The clinical nurse specialist is an advanced practice registered nurse, and they deserve to be credentialed and privileged and to be able to practice at their full scope. And I just think that if every nurse had a CNS to go to, we may not be dealing with the nursing shortage and some of the issues that we're dealing with right now. And then the last thing, Nick, I think I would say is graduate nursing education has been very focused on filling the physician shortage. That I think it's really time that some of these great minds in nursing go into CNS programs and become CNSs so we can really deal with the nursing issues and the nursing shortage.
Mitzi, thank you so much for taking time to talk with me today. All things clinical nurse specialists. I learned a lot, and hopefully, there are nurse leaders that are listening can think about how they can leverage CNSs more effectively in their respective sites.
Thank you, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.